Hello, everyone. Thank you so much, Kirk, for organizing this event and for the kind invitation. My name is Tai-Te Ted Su. I was a former postdoctoral researcher in the Department of Physical Therapy at U of T. Today, I will present our research on dual trajectories of disability and physical activity among adults aging with HIV, specifically findings from a population-based study in Ontario, Canada. To begin with, a huge body of research has shown that adults living with HIV may experience various health-related challenges, which can be termed disability in everyday life. In the meantime, we also know that physical activity can be a promising strategy to reduce disability. It is important to emphasize that disability and physical activity can influence one another, and both may change over the course of aging with HIV. However, very few studies to date have looked at them longitudinally. The Ontario HIV Treatment Network Cohort Study, or the OCS for short, provides a great opportunity to study disability and physical activity over time. The OCS was first established in 1996, and it is the largest community-governed HIV cohort in Ontario. The OCS collects a large volume of data that can help us better understand the health and challenges among adults aging with HIV. So using the OCS as the foundation, our study had three objectives. First, we aim to identify distinct disability trajectories and describe the participant characteristics within each trajectory. And second, we aim to identify distinct physical activity trajectories and then also describe participants' characteristics. And third, we will explore how disability and physical activity will correlate with one another over time. So we conducted a longitudinal observational study using data collected between 2020 and 2023. We set 2020 as the baseline because it was the first year that both disability and physical activity were measured. We included 1,709 participants in total who completed the 2020 assessment. In terms of measurements, disability was measured using the 12-item WHO Disability Assessment Schedule, or WHODAS for short. The scores can range from 0 to 48, with higher scores indicating more severe disability. As for physical activity, participants reported the number of days they engage in moderate or vigorous activity in the past week, so the score can range from 0 to 7. For analytic strategies, we applied group-based trajectory models to identify different disability and physical activity trajectories over time. And then we use dual trajectory models to assess the linkage between these trajectories that we identified in the first step. So coming to the results, at baseline, over 70% of participants were recruited from Toronto. The mean age was 52.2, and most participants were identified as men and as white. About 40% had a university-level education or higher. And for our first research objective, we identified 4 different disability trajectories over time, and they can be labeled as no disability, low disability, medium disability, and high disability. These results deliver 2 important messages. First, adults aging with HIV, they can experience different levels of disability. And second, even within the same trajectory group, we notice that there is a lot of variability, or in other words, there are substantial year-to-year fluctuations in the level of disability over time. Next, we look at who was in each trajectory group. We found that women were overrepresented in the high disability group. In contrast, participants who identified as Black or African had higher education or greater household income. They were more likely to be in the no disability group. People who smoke and use substances were more often found in the high disability group. And at the bottom, we found a clear gradient where people in the higher disability groups, they reported more stigma and less social support. Moving on to our second objective, we found 4 physical activity trajectories as well. About 17% of participants remained barely active between 2020 and 2023, while 45% stayed highly active during this time. It is interesting to note that a portion of participants showed a decreasing trajectory, while others increased their physical activity over time. We also observed substantial fluctuations across the study period. Next, we look at participant characteristics in each group. We can start with the most extreme comparison, which is barely active versus highly active group. We found that women were overrepresented in the barely active group. In contrast, participants with higher education, greater household income, and those who never smoked were more likely to be highly active. Participants with more comorbidities, higher stigma, and lower social support were more likely to follow the barely active trajectory. And when it comes to the middle two groups, it is surprising to see that the characteristics are quite similar. The only notable difference is that people who smoke tended to exhibit a decreasing activity trajectory. So far, we've looked at disability and physical activity separately. Now we want to understand how they correlate with one another. And to do this, we intersect all trajectories and check which combination is most common. And we can formally express this as the joint probability. Using this 4x4 table, we found that the most common pattern was being highly active and having no disability, followed by highly active with low disability. It was very rare to see someone who was highly active and had high disability, or someone with increasing activity and high disability. Okay, so to sum up, in this study, we found that disability and physical activity among adults aging with HIV are both diverse and dynamic. This really highlights the importance to recognize and examine the within and between person variability over time. Our findings underscore the need for continued monitoring and adopting a person-centered approach to care. Second, we found that differences or disparities exist between people following different trajectories. And this information is important to guide us on how to allocate resources and design interventions to meet the specific needs of each group. Third, we also found that higher physical activity is associated with lower disability. Although we are not able to strictly determine the causal relationship, our findings suggest that understanding the pattern of one may provide insights into the other, and our efforts to promote physical activity may be worthwhile in reducing disability as well. Our study has several strengths. For example, our findings are grounded in a large prospective cohort of adults aging with HIV in Ontario. However, we want to acknowledge that our measurement of disability might not reflect all aspects of the challenges they experience. For example, mental emotional challenges or uncertainty, they were not measured in WHODAS. In addition, we need to be cautious that things happen between the annual assessments may not be captured in our study. And our next step is to explore long-term trajectories and to identify what are the common factors or mechanisms that may influence both disability and physical activity among this population. Finally, a special thank you to the OHT and the OCS and all the participants for making this research possible. I would like to thank my mentor, colleagues, and collaborators for their tremendous contributions to this study. And thank you all for listening.